Welcome to Module 7, Pressure Ulcer Management. Pressure injuries, commonly known as bed sores or pressure ulcers, are among the most preventable yet costly complications in healthcare. They can occur in hospitals, long-term care facilities, and even at home, especially among immobile or critically ill patients. In this module, you'll gain the knowledge and tools to recognize pressure injuries early, prevent their formation, and manage them effectively if they develop. This isn't just about wound care, it's about protecting dignity, preventing suffering, and ensuring quality of care. By the end of this module, you will be able to explain the causes and risk factors that lead to pressure injuries, including mechanical and physiological elements. Identify and stage pressure injuries accurately using the NPIAP, National Pressure Injury Advisory Panel. Classification system from stage 1 to deep tissue and unstageable wounds. Apply prevention strategies grounded in clinical evidence, like repositioning, offloading, and using pressure-relieving surfaces. Document and communicate wound status effectively to guide the plan of care, prevent deterioration, and meet legal and accreditation requirements. Every patient you protect from a pressure injury is a victory for compassionate, evidence-based nursing care. Let's start with the basics. What are pressure injuries? A pressure injury is localized damage to the skin and underlying soft tissue, typically over bony prominences like the sacrum, heels, or hips. These injuries are caused by sustained pressure, or a combination of pressure with shear and/or friction that compromises capillary blood flow, depriving tissue of oxygen and nutrients. This leads to ischemia, cell death, and tissue breakdown. Moisture from incontinence, perspiration, or wounds further weakens the skin, increasing vulnerability. They're not just a skin issue, they can lead to pain, sepsis, prolonged hospitalization, and even mortality. As nurses, your vigilance and early intervention are critical in breaking the chain before tissue damage occurs. Understanding why and where pressure injuries occur is essential for effective prevention. Etiology, main causes include pressure, the primary cause. If external pressure exceeds 32 millimeters of mercury, it can collapse capillaries, cutting off oxygen. Shear happens when skin stays in place but underlying tissues slide, common when the head of bed is elevated. Friction occurs when skin is dragged across a surface, like bedding, damaging the epidermis. Moisture weakens skin integrity. Sources include urine, feces, sweat, wound exudate, or prolonged use of moist dressings or devices. Common locations: sacrum, most frequent site in bedridden patients. Heels, especially at risk due to poor perfusion. Trochanters, side-lying patients. Ischial tuberosities, wheelchair-bound or seated long hours. Elbows, occiput, scapula, especially in frail or unconscious patients. Recognizing mechanical stressors and vulnerable anatomy equips you to implement timely interventions like turning schedules, heel offloading, or moisture barrier application. Some patients are more prone to developing pressure injuries than others. Understanding the risk factors helps you act early and prevent harm. Key risk factors include immobility. Patients who can't reposition themselves due to surgery, sedation, stroke, or paralysis are at highest risk. Even short periods of immobility can cause damage. Poor nutrition and hydration. Without enough protein and fluids, the skin and tissues lose their ability to repair and resist pressure. Excess moisture, from incontinence, perspiration, or wound. Exudate. Moist skin is fragile and breaks down faster under friction or pressure. Sensory deficits. Patients with conditions like diabetic neuropathy or spinal cord injury may not feel the pain or pressure that would normally prompt movement. Poor circulation. Peripheral artery disease, hypotension, or heart failure reduces tissue oxygenation, delaying healing and increasing risk. Advanced age and comorbidities. Elderly patients often have thinner skin and more complex medical conditions like diabetes or infections. further compounding the vulnerability. Clinical tool, the Braden scale evaluates 6 domains: sensory perception, moisture, activity, mobility, nutrition, and friction jar shear to predict pressure ulcer risk. A score less than or equal to 18 signals increased risk. Use this proactively on admission and regularly during care to guide targeted prevention. Correctly staging a pressure injury is vital. It shapes the treatment plan, determines severity, and ensures proper documentation for legal and regulatory purposes. NPIAP, Staging System. Stage 1. Intact skin with non-blanchable redness over a bony prominence. The earliest warning sign, pain, warmth, or firmness may also be present. Stage 2. Partial thickness skin loss involving the epidermis and/or dermis. Presence as a shallow open ulcer or blister, usually moist and pink-red. Stage 3, yellow full thickness, tissue loss with visible subcutaneous fat. No bone, tendon, or muscle exposure. May include tunneling or undermining. Stage 4, full thickness loss with exposed bone, tendon, or muscle. High risk of osteomyelitis or systemic infection, often deep and necrotic. Unstageable. The wound base is completely covered with slough, yellow, or eschar, black, making depth impossible to determine until debridement. Deep tissue pressure injury, DTPI, appears as a persistent dark red, maroon, or purple area under intact skin. Indicates deeper damage beneath the surface, often from shear or intense pressure. Accurate staging requires good lighting, knowledge of wound tissue types, and ongoing reassessment as the wound evolves. Meticulous assessment and documentation are cornerstones of safe, effective wound care and critical for both continuity and accountability. Assessment parameters include location, over which bony prominence, stage, as per NPIAP classification, size, measure length times width times depth in centimeters, tissue. Type, describe what you see, granulation, slough eschar, or epithelial tissue. Exudate, note type, serous, purulent, color and amount, scant, moderate, heavy. Peri-wound. Skin, look for signs of maceration, redness, induration, or breakdown. Odor and pain. Strong odor or increased pain may signal infection. Tunneling, dust undermining. Use a cotton tip applicator to explore wound edges. Documentation tips. Use objective, standardized language. Update charts at every dressing change. Photograph wounds, if policy allows, for clarity and progression tracking. Report significant changes to your team during handoff or wound rounds. Proper documentation supports quality audits, insurance claims, and patient safety. The best way to manage pressure injuries? Stop them before they start. Prevention is a multidisciplinary, team-driven effort, where nurses lead the charge. Core preventive measures. 1. Frequent repositioning. A. Turn patients every 2 hours in bed and every hour if seated. CRB. Use a turning schedule or positioning chart. 2. Support surfaces. A. Use pressure-relieving mattresses, air, gel, foam for high-risk patients. B. Elevate heels off the bed using heel boots or pillows. 3. Skincare and moisture control. A. Keep skin clean and dry. B. Apply barrier creams for incontinence. C. Use breathable underpads and moisture-wicking materials. 4. Nutrition optimization. A. Screen for malnutrition. B. Encourage protein, zinc, and fluid intake. C. Collaborate with dietitians for supplements or enteral nutrition. 5. Promote mobility and independence. A. Encourage sitting up for meals, walking when possible. ISHB. Provide range of motion. ROM. Exercises to bed-bound patient circa. Ensure proper assistive devices for repositioning. Every reposition, every heel offload, every barrier application, it all adds up. Prevention isn't just a protocol, it's a mindset, and it saves lives. Treatment for pressure injuries must be tailored to the stage of the wound, the patient's overall condition, and any signs of complications, Stage 1 and Stage 2 injuries. Begin with gentle cleansing using saline or a non-cytotoxic cleanser. Apply moisture-retentive dressings like foam, hydrocolloid, or film to maintain a moist healing environment and protect from further trauma. Minimize friction and shear by using protective padding and educating caregivers on safe repositioning. If the wound is from moisture, incontinence-associated dermatitis, incorporate barrier creams and improve incontinence management. Stage 3 and Stage 4. Injuries. These are more complex and often require interdisciplinary wound care. Debridement, surgical, enzymatic, or autolytic, may be necessary to remove necrotic tissue and promote granulation. Use advanced dressings like negative pressure wound therapy, NPWT, alginates, or silver-impregnated dressings based on exudate and infection status. Infection control is vital. Take wound cultures, swab, or tissue biopsy. If there's odor, drainage, or delayed healing, start empirical antibiotics and adjust based on culture reports. Pain management, nutritional support, and pressure redistribution are essential components of comprehensive care. Timely referrals to a wound care team can significantly improve healing and reduce complications like sepsis or osteomyelitis. Pressure injuries are classified as never events, meaning they're largely preventable and should not occur in a well-managed healthcare setting. This makes accurate documentation and prompt reporting essential for every nurse and care provider. Documentation must include date and time of detection, precise staging using the NPIAP system, wound measurements and tissue descriptions, repositioning, dressing changes, and patient education provided. Photographs, if allowed by facility policy, legal and administrative implications. Stage 3 and 4, hospital-acquired pressure injuries, CHAPIs, must be reported to hospital quality departments and possibly to state or national regulatory bodies. In the U.S., they can affect Medicare reimbursements, trigger sentinel event investigations, and lead to litigation if not managed transparently. Thorough, timely charting ensures protection for the patient, the provider, and the institution. Documentation isn't just paperwork, it's patient advocacy, accountability, and risk management. Let's wrap up what we've learned in this module. Pressure ulcers are one of the most preventable complications in patient care, and nurses are at the forefront of both prevention and healing. Key takeaways. Identify risk early using tools like the Braden Scale. Stage accurately using clear guidelines. Prevent with proactive care, repositioning, nutrition, moisture control. Treat promptly using evidence-based wound management. Document thoroughly and escalate care when needed.